Many clinicians see themselves only as doctors, not entrepreneurs. How did you develop the mindset of both a clinician and a business owner?
It comes very unnaturally. I think most doctors, they go through high school learning and cramming lots of knowledge, trying to be, really good in their exams, get good scores, get into medical college. And again, there's a lot of information that they're collecting, which is very medical, clinical, biological information. So you become very good at knowledge acquisition. It's all very focused on, physiology, biology, biochemistry. And then for me, in my case, after finishing medical school, I did, 15, 20 years of surgical training to become a consultant. So that was, it's very linear, and you end up becoming really, really good at the technical, for me, skill aspects of being a clinician, but actually doesn't prepare you for all the other things aside from your technical expertise. So in terms of running your team, for example, managing budgets, managing finances, people management, you can read the largest surgical textbook and all which instruments to use when you're doing a particular operation. It doesn't teach you how to manage a team and resources. So those are things that I've had to learn separately, and I'm probably still in that learning journey. I'm probably still not the best at managing the things outside surgery than I am within my area of expertise. But I'm more aware of it now than I was perhaps 20 years ago.
How do you design your patient journey so that it feels seamless from first contact to all the way to follow-up and aftercare?
So my workload involves lots of NHS patients and NHS work, and then there's a separate private element to the work I do. And there's a difference in case mix. So in the NHS, I'm doing some hernias, but also lots of cancer. So big, long, 6-hour operations using the robotic surgery equipment that we have for the last 3 or 4 years at Ipswich. So it's very meticulously planned. There's lots of extra support. For cancer patients, we spend a lot of time talking to them about the risks of surgery, and actually there is some element of probability calculations about, what's the probability of a complication going through long, difficult, challenging surgery, what could go wrong, how likely is it to go right, and what patients want to know in the NHS when I see them is how long are they going to live if they're going to have the surgery for cancer. So the stakes are very different. In the private sector, it's a very different case mix, and the environment's very different. So there are fewer patients, so it's a lot more relaxed. You can actually spend a lot of time for the slots that you have for each patient. So even a hernia patient will spend half an hour, 40 minutes talking hernia surgery. So in the NHS, there's no way you can do that. For a hernia patient, you have literally 10-minute, 15-minute slots. And you book them, you talk to them a bit, and then you move on to your next patient because they're all crammed and packed. But in the private sector, it's more relaxed pace. You can talk to the patient about what their goals are for the next 2 or 3 months and work around, the timing of surgery, for example. They get to plan when they have it around their normal life. And you can have a nice detailed conversation about how the surgery will impact their ability to, say, work, for example. So it's a very different, more personalized approach in the private sector, I would say. So you don't have, say, a specialist cancer nurse who's going to come and sit down and talk to the patient for an hour after you've spent half an hour with them. So you have to do it yourself, but it's a lot of one-to-one interactions with a consultant and a patient in the private sector. So the case mix is different as well. So there's a lot more hernia patients, a lot more small procedures, diagnostic procedures like colonoscopy and gastroscopy and sigmoidoscopies, and then treating what we might describe as minor procedures, which in the NHS might get done by a slightly more junior person like a registrar. But in the private sector, the consultant will be doing things like banding of hemorrhoids or injection of hemorrhoids. So those sorts of what we call minor procedures, they are done by a more senior person. And I can talk to them about, it's a 1-minute banding procedure, but I can talk to them about it for 10 minutes before I do it. And there's no way you can do that in the NHS. There's literally no time. So I think it's more rewarding at a personal level. I find the private work that I do, it's less work, more relaxed, more time for the patients. And I think patients really appreciate that extra 20 minutes, half an hour that they get to discuss, their hopes and fears and needs with respect to the symptoms they have.
What role do collaborations play in building a successful private medical practice, and what type of collaborations do you feel like are the most important?
So collaborations between the clinicians in the private hospital and perhaps the GPs are important, because GPs have a patient that they want to get sorted. They want their clinical issues resolved. They want help and support and guidance about managing the patient on a long-term basis once the initial diagnosis and treatment's been made. So communicating with the GP, I find, is really, really important. And in the private sector, you can actually spend more time writing a more detailed letter to the GP, advising them about what to do to take things forwards. Often we have patients with, say, inflammatory bowel disease. So I'll do the colonoscopy, make the diagnosis, and then if it's more complex forms of inflammatory bowel disease, I might refer them to another specialist to look at that. With things like pelvic floor disorders, so I manage a lot of pelvic floor disorders like fecal incontinence and obstructive defecation syndrome, and we will get the physiotherapists involved. Sometimes we send them for specialized anal physiology and ultrasound scan testing elsewhere. So there's a lot of collaboration with the GPs, physiotherapists, other allied health professionals, other areas which we perhaps haven't developed, but are, I guess, talking to you and your team, I'm interested in developing is the website and other aspects, which by developing those areas, hopefully we can communicate with patients directly and make them aware of the services that are available should they choose to go ahead.
Do you think the demand for private medical care in the UK will continue to rise over the next decade? And if so, why?
I think demand will definitely rise. One, we've got people living longer. So whereas in the old days, you'd retire at 65 and most people will be dead at 67. Now people are living to 85, 86, 90. So that's putting immense strain on the NHS. I was a cancer lead for colorectal cancer at my hospital for 5 years. And I have literally seen the change in the referral pathways and patient volumes over those 5 years between 2017 and 2022. So we had about 150 patients a month being referred with suspected bowel cancer. And we actually redesigned the team and introduced a straight to test service and increased the throughput. We appointed extra consultants, so hired 2 more consultants to the team. But referral numbers have doubled. So we're getting 300 to 500 referrals a month now. So it's just astonishing the volume of referrals, how they've gone up over those 5 years. So we were treading water, barely back then. We're still kind of always on the verge or sinking in the NHS. So those patient volumes have really increased. There have been guideline changes which have had that impact as well, but people are definitely living longer. The NHS can't cope. There's no extra funding. People need their clinical concerns looked into. So people have symptoms. They want to know what's going on. Why do they have pain in the belly, for example, or why are they bleeding in the bowels? And the system can't cope with that. So there's long waiting times for getting seen or reviewed and having the tests. And so I think more people are going to shift to the private sector and in order to have more control over how soon they get seen and what setting they have their tests done. So I think it's only going to rise in the coming months and years.
I'm on the same page as well. I agree with much of the factors you just said. So how do you balance your clinical time with administrative and strategic time in your week as a private practice owner in the medical field?
So I have set times where I operate and in clinics. I was, like I mentioned, I was doing lead work for cancer for several years. So that generated an immense amount of admin work on me personally. So I was simultaneously running a full-fledged consultant surgeon, practice as a consultant surgeon in the NHS. And I was also running the cancer lead work, which was layered on top of everything else. And I don't know if you know too much about the burden of colorectal cancer, but the admin workload is immense. And the volume of patients is one of the highest for most NHS hospitals. So a lot of senior NHS managers are very worried about the benchmarks, whether they're being achieved, whether they're hitting the targets or not hitting the targets. So there's a lot of executive level pressure on individual colorectal cancer teams. And I realized that actually I hadn't really organized my NHS practice in a kind of a sensible way. And that was a good learning experience. So when I switched to becoming the lead for surgery at Ipswich, I then decided to cut back on some of my elective NHS work in order to then be able to focus better on being a lead. So if you're a leader, that does require time and effort, and you need that space to actually think about things and come up with creative solutions. Often when you're encountering a problem, you don't have an answer straight away. and you think about it over several days. And often it's in the weirdest of moments when you're actually doing nothing, or you might be sitting in the garden and suddenly an idea jumps up at you and it works. So you need that kind of, I realized it the hard way that you have to kind of balance the two sides really well. So I've got time that I set aside for my private work. And so when I'm in the private sector, I'm only focused on my private patients. When I'm in the NHS, I'm only focused on my NHS patients. So there's a nice kind of clear boundary there between the two.
So how can medical consultants stand out in competitive areas and markets where, perhaps maybe multiple consultants are offering, similar services?
So firstly, providing really good care to the patients you are getting, and making sure that all their fears and concerns are resolved, that they get the right treatment, that they have a good outcome, showing concern for them. So if your patients will be your best, your best source of support for getting future patients. So word of mouth. I mean, whether it's some work, DIY work you want done in your home, getting a kitchen fixed, or something done in the bathroom, you go by word of mouth. So same happens with clinicians. If you have a good surgeon who provides a good outcome to you, treats you well, and you're happy with the care you receive, then you're going to tell other people about it. So last week, when I was in my clinic last week, one of the patients said that they had their best friend come to see me the week before, and they were so happy they asked their best friend to come and see me the week after. So that's what you can do at a personal level. Now, that helps, but there are still limits to how far that can go, because there's a limited sphere of influence that your individual patients will have, welcome though it is. And I think beyond that, some sort of digital presence is helpful, because it means if someone who's never met you before wants to get additional information about you or the sort of surgery that you do, that they're able to get that information without having to come and see you directly. So some sort of online digital information via a website or some other kind of media approach provides patients that opportunity to get the information if they need it.
What's the biggest financial mistake you see consultants make when starting and trying to grow?
So it's quite difficult getting information about consultants' private practices, because there isn't a lot of easily available data on what consultants do at an individual level. So it's quite difficult, but going by personal experience, I think one of the key issues that I realized over time was not formalizing my private business. So I was turning up in the private hospital, seeing lots of patients, doing lots of procedures, but I hadn't formalized it by doing things like setting up a company, a limited company, organizing the work that I do in the compartments from the point of view of expenses, for example. So not many people are aware that you can claim business expenses for the part of the time that you spend at home doing business work activity. So you can claim some of those expenses there, and also your revenue that you generate ideally should be going through a private company into a private business bank account as well. So that is really important to compartmentalize the two and ensure that it's very clear, and separate your business finances from your personal expenses.
When trying to grow a private medical practice, how do you know if it's the right time to hire somebody to help you with it?
I think what I would advise new consultants to do is to probably start some private practice for at least a year or 2 years, just to become familiar with the insurance landscape, get the registrations, and get onto the provider lists. And get into the swing of managing their private secretary, and having a presence in the private hospitals. So you need practicing rights within your private hospitals. You need to have the practicing rights within the hospitals. You need to have the practicing provider rights with the insurance companies. I would recommend that they try and register with as many insurance companies as they can. There's 2 or 3 big ones, so probably register with the 2 or 3 big ones at the very least, but try and register with as many as possible. So once you've got an up and running practice, I think it would be a good idea probably to get in touch with some sort of digital marketing team sooner rather than later. Now, you don't have to necessarily get in touch with an actual separate team. You could try and do it yourself if you have the time. So you could set up your own Instagram account, for example, and post some material there that might be helpful for patients. Maybe talk to them about the sorts of operations that you might recommend for certain conditions, or the sorts of symptoms to watch out for, and seek medical attention, whether it means seeing their GP or seeing specialists. So you can start some sort of thing like that, but do it early rather than late, because then you'll probably benefit from you know, the advances in patient numbers and revenue, and promote your business early on rather than later. I've kind of limited time professionally, so we all at some point we all going to have to retire. So if you have, say, 25 years of functional life, then you want to kind of maximize your business work, you know, for majority of those 25 years rather than, say, the last 2 years, for example. So soon is better than late.
How can consultants future-proof their private practice against changes in NHS policy, PMI policies, the way private hospitals do their work, or even just patient expectations? How do you future-proof your private medical practice regardless of what happens in the industry?
That's a really tough question and a really interesting question. I think you can't guarantee that you as a clinician will be future-proofed. So, for example, about 40, 50 years ago, one of the bread and butter operations for bowel surgery was doing a gastrectomy or distal gastrectomy for peptic ulcer disease. And so there's a lot of emergency and planned operations that were being done for people with peptic ulcers and people doing vagotomies, for example. And just one drug came out, ranitidine, and a whole class of antihistamines that came out, and now we've got the proton pump inhibitors. These tablets at a stroke have wiped out this entire workload, apart from very occasional emergency surgery that's sometimes required. But the bread and butter operation of a distal gastrectomy is now gone out of the window for benign conditions now. So I think every industry is at risk of being impacted by changes that happen, and those changes may occur despite your own personal performance. You may be an excellent surgeon, but if the business goes, it goes. So a lot of vascular surgery is changing because of the rise in stenting, for example. So the interventional radiologists will put stents in, they'll do balloon angioplasties. A lot of cardiac surgery is changing as well. So the volume of cardiac surgery is going down because it's certainly in places where stenting and angioplasty, a lot of percutaneous interventions are available now to do things in a minimally invasive way. Without requiring a big heart operation, for example. So I don't know. I'm a bowel cancer and hernia surgeon. I think the hernia workload is probably unlikely to change. That's probably going to stay. The cancer workload, maybe if some new drugs come out, the hope is, I say it's a hope, even though it might go down, that maybe some drugs come out and cancer becomes a bit more like diabetes. So it's a lifelong condition, but it doesn't kill you. You take tablets every day and you keep on going. So some cancers are already like that for the vast majority of patients. So like prostate cancer, some forms of, breast cancer will be like that. No, not all breast cancers like that. But there are certain cancers that are already like that where you take medication, every so often and you can go on almost indefinitely. It could take another 10 years for that to happen. So you might find that, or I might find that my practice drastically changes in the next 10 or 20 years. The big change in the last 5 years in the UK is the rise of robotic surgeries. And what I have discovered is that it pays to be adaptable and look out for those changes, and instead of trying to oppose the change, but actually ride the change. So we've started doing robotic surgery at Ipswich Hospital, and we've all gone through the learning 3 or 4 years, and we set up a really good practice. So I was actually meeting yesterday with one of my colleagues, and they've looked at the data for the operations we've been doing, and we've brought down the length of stay by 2 days after, 4 to 6 hour long operations for cancer. People are getting less pain after surgery. They're going home sooner. We're actually getting more lymph nodes out as well. So potentially they might even live longer because of the robot surgery that we're now doing. So that's a really nice outcome for our patients. Looking at a change that's taken place, in the last 4 or 5 years. I think robotic surgery is here to stay. It's going to go probably expand. A lot of hospitals are currently buying a robot right now. So any hospitals that don't have a robot are going to be left behind. They're going to be left behind in terms of the care they can provide to their patients, but also the trainees. They want to be trained in robotic surgery. So they are they pick and choose where they go. They will go to centers where they can get the training they need in order to become more marketable as consultants at the end of their training. So we have now, probably the first year or two, I was just trying to go up the learning curve myself. And now that we're established, I'm starting to train people. And so Ipswich is becoming a big center for training surgeons in how to do robotic surgery going forwards. So that's great for the department. It's great for the team. It's great for patients. I think that could be replicated across the specialties. robotic surgery can be expanded potentially to things like it's already established in gynae and urology, but it can be expanded to, say, ENT surgery, thyroid surgery, dental surgery. So basically, it's a platform it's an expensive platform, but it's a platform for really good, meticulous control of the instruments with very detailed views on effectively a 3D platform. So it's basically what you end up doing is very slow, but very gentle and very meticulous surgery. And that's something that's going to carry on expanding, I think, globally.